Next one. The next one in the series of mechanical ventilation is mechanical ventilation. Where do we stand now after COVID? What did we learn, and what does the future hold? So after the ideas, we'll go with the COVID thing and how things have changed or in mechanical ventilation. To take this forward, we have Dr. Rajesh Pande, who's a very senior director and HOD of the critical care from BLK Max from Delhi. And the interviewer would be our own Dr. Anand Joshi. So Anand, he's presently joining us live from Adelaide. So Anand, take it forward, talk to Dr. Rajesh and extract all the info that you would want to. Right.
Good afternoon all, and welcome to another fantastic session of CRITIC 2021. I'm Dr. Anand Joshi. I'm one of the intensivists from Hyderabad, and today I'm here to host an interview from our expert, Dr. Rajesh Pande, who will be joining us. And we'll be talking on mechanical ventilations during the COVID and how it has changed our approach and what the future holds for us. Welcome, Pande sir.
Thank you. Good morning.
So Pande sir, it's always been this last 1.5 year or 2 years had always been quite challenging for us, which has completely changed the paradigm of how we approach to an ARDS. Secondary to any kind of infection. It took us almost 20 years to have set protocols with a improvement in the mortality for management of ARDS, especially when it came to the mechanical ventilation. However, the COVID things seems to have changed a bit of perception. So I would like to know from you to start with, how do you find the COVID ARDS or the cards, as it is called, different than the routine ARDS, specifically focusing on the genotype and the phenotype, the phenotypic classification, which was given by Lucia Gattinoni and his colleagues. So, what is your opinion on that?
Thank you. I agree with you. When we started realizing that we have gained sufficient ground in terms of our understanding of ARDS and the management, especially after the Burlington and the subsequent algorithmic approach, we thought we are doing fine. Although lung safe study was an eye opener that showed us that a lot of us still do not recognize ARDS in our patients, and the mortality still remains high. So especially for severe ARDS. But this, like you said, this CARDS or COVID associated ARDS has really been an eye opener. Despite whatever we knew and we have been managing for almost 2 decades since the ARMA trial was published. But we found that, we were feeling helpless as our patients. So, talking about CARDS, this was, although technically it qualifies as per the Berlin definition, except that maybe, Berlin definition, we said the inciting cause should be less than 7 days in duration, acute in onset. So here we find it is beyond 7 days, 8 to 12 days. So that is one difference from the conventional ARDS that we find. And the second thing, possibly this is more to do with the vascular thing rather than the gas part. So possibly there is more of endotheliopathy that we see in COVID associated ARDS as compared to the regular ARDS. So these were some of the subtle differences that we found, and based on that, in the initial part of the COVID, I think that was when we had the first surge, started from Wuhan, China. Gattinoni and John Marini wrote a paper in JAMA where they said that this is slightly different than the usual ARDS that we see. And They said it is more to do with the vasculopathy in COVID ARDS, more of thrombosis and other things. And they, because by that time we had a lot of Italian data coming up besides the Chinese data. So they said that possibly we are having two different kind of patients who are presenting to us. And one would be those who come like a classic ARDS where the compliance is low and there are bilateral infiltrates, heterogeneous infiltrates in the X-ray. And there they said that this is the H phenotype because the elastance is high and the compliance is low. And they suggested, it was a suggestion, that we should ventilate these lungs in case we are intubating them in the usual way, like we do the ARDS. We can go for high PEEP. They suggested more than 15 centimeter of water. So besides low tidal volume ventilation. And then they said that we are also seeing another group of patients where the compliance is nearly normal. So they call it elastance is low. So they call it the L phenotype. And they said here we can choose higher volume, 7 to 8 ml per kg. And here we should be using lower PEEP. So that was, their thought process. And they showed in some of the things that there were more, vascular changes in these lungs affected by COVID. But subsequently, when in our experience, like we found a lot of, patients who came to us with happy hypoxia, they were grossly hypoxic, but they didn't realize and they were quite okay with the amount of hypoxia that we were seeing. So the symptom was much less compared to the degree of hypoxia that was seen there, but we didn't see any clear H or L phenotype. There was a lot of mixing up. So you had patients who were like classical ARDS, who presented in classical ARDS kind of a situation, and some where you find that they were quite okay despite being hypoxic. So it was a mixed bag. And surprisingly, we couldn't use the high PEEP as they had suggested in patients who had a low compliance. So because we found the incidence of barotrauma was extremely high in these patients.
Right. So yeah. So that's quite intriguing because just a doubt here is though these two phenotypes were explained, is it possible that these phenotypes represent the different pathophysiological stage of a disease, and we can still have both the phenotypes expressed or clinically evident in the same patient at the different stage?
Quite likely. Things begin in the initial part as the normal compliance, and then gradually, if there is no healing, then it progresses to classical ARDS and the situation worsens. So in both, the common denominator is that there is significant degree of hypoxia. So I would agree with you that this may just be the beginning of the full-blown cards in this group of patients.
Right. So there was some discussion about some phenotypes which also occurred before the COVID. Can you please elaborate a bit on that?
Yeah, sure. See, we have been trying, the researchers in our ARDS field have been trying to find a solution to reduce the mortality. And the Berlin definition, in fact, this definition before also when they looked at ALI and ARDS, these were two different subsets. And Berlin, they said mild, moderate, severe based on, the presence of more than 5 centimeter of PEEP plus the PF ratio. So that was some attempt to identify three distinct kind of patients where the mortality for severe and, moderate to severe would be high. The treatment modality, the algorithmic approach also was different there. And for example, the non-invasive could only be tried in very mild cases. It was not to be used in moderate to severe cases. So, but then we had some seminal work published from USA. Calfee et al., they were part of the National Heart Lung Institute and the ARDS network. What they did was they revisited the ARMA and alveoli trial. So when they revisited the trial, they looked at they tried to identify whether the patients were any different. So they looked at the biomarkers and they identified two different distinct type of patients. One was, you can say, hyperreactive. The other was hyporeactive. or hyperinflammatory and hyperinflammatory. In hyper, they found the inflammatory markers were high and the mortality was high, metabolic acidosis was high, vasopressor requirement was high, more of them were in septic shock, and these patients require higher amount of PEEP also. Compared to, situations where the inflammatory markers were low. So they were not as high. So there they labeled it as hypo-inflammatory. And there they found that the vasopressor requirement was less, the severe sepsis, septic shock was less, the metabolic component, metabolic acidosis was also less, and the PEEP requirement was not so high. The outcome was better. So that was the initial attempt. And then they, applied this information on the patients of alveoli trial, previously published by the ARSNet group. And they could find a similar result that, this was going well, that those who were hyperinflammatory, they would have higher mortality. And subsequently, another study where they looked at the application of this in FACT trial, that was again an ARSNet trial, which looked at restrictive versus liberal and CUP versus pulmonary artery, that trial. So there they observed that they had a sort of hyporeactive and hyperreactive subtypes. And the hyperreactive, they found that the mortality was less if restrictive fluid strategy was used. It was significantly more if in these patients liberal fluid strategy was used. So they could again show that possibly there are patients who behave differently. And if we, what they suggested is if further research is done based on these inflammatory markers, for example, hypo and hyperreactive would behave differently, possibly will be more closer to the solution in terms of what is best for these patients. So, but again, it's a largely remains a scientific concept. So practical application, we do not know.
Exactly. I was coming to that. So while there seems to be quite a bit of research and the clarity happening about the classification of the patients when they are coming to us, but what's there at the bedside for us, means the recognition of these patients and understanding them. So let's start with the simplistic thing. So I have got a patient who is coming to me who's diagnosed at COVID and has got X comorbidities, and he's coming to me and he's got a hypoxemia. So please guide us through this, the algorithm or the pathway, that how do we escalate stepwise the therapy for the patients who are admitted with worsening hypoxia, particularly in this COVID patients.
Great. So I think this is what most of our friends and colleagues in India were doing. The idea was to maintain target adequate gas exchange by doing whatever, modalities were available to us. And in fact, the step-up approach would be similar like in any other usual ARDS patient. Say, for example, what we did, because this second surge was really very bad in India. So we were running short of equipments and other things also. So what we did was NRBM was a standard initiating therapy for patients who were hypoxic. And then gradually then we had to choose between HFNC and NIV in these patients. If we found that they were still, the work of breathing was high. HFNO, because we had a problem with oxygen supplies also. So there was a time when we were advised to use it minimally because it consumes oxygen quite a lot, that we realized here. And same with the turbine-based ventilators. They also consume oxygen quite a lot. So we realized that these were not very good, choices in situations where we have a significant number of patients with us. So anyway, so HFNO, but it has a limitation that we can get at 60 liters flow, we can get a CPAP of 5 or 6 maximum. So that is the limitation. Yeah. And again, if we are just being oxygen centric or SpO2 centric or PO2 centric, then we may be using very high amount of oxygen. We can go closer to 100% here. NIV, on the other hand, I consider it a higher form of support because you can increase your IPEP and EPAN at the tidal volume. You can add oxygen. The problem is that the titration and the monitoring is not so good as in the invasive ventilators, but a lot of us were using invasive ventilators also to provide an IV. So that was how it was happening. So if my patient is in the high dependency unit or in the ward, I would put him on, BiPAP machine. And once he is moved, he is not improving, he would move to the ICU. I would put him on an IV. Now, one word of caution here, because these patients, what we found in cards were they were tachypneic. They were breathing very deeply and the spontaneous activity was quite intense. The minute ventilation was quite high. So whether we allow them to breathe spontaneously, because with these modalities, we have no clue as to what is happening to their driving pressure or the transpulmonary pressure. But I believe physiologically, if they are taking very deep breaths and they are generating quite high minute ventilation, then obviously there would be significantly high transpulmonary pressure also. So that
I will come to that. I will come to that concept before that.
Okay.
Yeah.
Okay.
So
Sure.
Yeah, you touched this this topic of second wave and the first wave. Now there is an obvious difference between the first wave and second wave. First wave, we didn't have any therapeutic guidelines, or there are no drugs or medications that can modulate the inflammatory response as against the second surge. Second surge, I think we had all the medications, but we were limited by the sheer numbers, especially in Delhi, where we had to rationalize the usage of the available equipments. I'm sure the things would be different and if everything was available. So how can you just enlighten us regarding what were the issues during the first waves, where even we were not knowing about the steroids and the use of tocilizumab and other anti-inflammatory drugs, which were much more streamlined now in the second surge, versus your approach for an ARDS during the second surge. If you can just highlight those aspects, then we can move out on the other things.
Sure. In the first surge, like we started with hydroxychloroquine and ritonavir, lopinavir. So, I mean, like you said, that information was trickling in. We didn't know which drug is effective. Remdesivir became available quite late towards the end of the first surge, and it was not available otherwise. There was a lot of scare because the aerosol spread was, highly publicized in the media as well as in medical journals. So people were frowning. They were afraid to use the BiPAP or even HFNO because of the fear. So gradually it dawned upon us that if we are wearing good PPE, taking all the aerosol precautions, then we can use these therapies, because otherwise what are we going to do? We can't intubate all the patients and ventilate them. So we, as a precaution, we also started using the bacteria viral filters at the expiratory end of BiPAP machines and, other things. So the emphasis was more on correct and adequate, use of the personal protective equipments. And ARDS, I would say we were treating them like the conventional ARDS initially. We were using high PEEP in the first surge. So we didn't know, and the initially published these Gattinoni and other papers, they also made us think that possibly there are two distinct phenotypes, HNL, which we gradually realized that there is significant overlap. We can't say with certainty. And like you suggested, that this could just be that they start with L and then gradually go into H type, as the disease worsens. So, but we found significant amount of barotrauma, and we were not clear, even steroids, we were not clear about the low molecular weight heparin also. There was not much clarity. Interpretation of the inflammatory markers, we were not very clear. So in second surge, as far as the drug part is concerned, we were very sure. Remdesivir was available, tocilizumab was available. We were sure to use dexamethasone. All those trials had been published by then. So things were pretty streamlined. The only bothersome thing was the number of patients that presented to the hospital. They overwhelmed the facility. So we were running short of ventilators and other devices. But the ARDS was pretty bad. So we had larger number of patients who were more sick this time in the second surge. And again, there was a difference because a lot of patients died in the first surge. So the media, news media and general public through WhatsApp groups, there was a message and people thought that anybody who would be intubated would surely die. So there was great reluctance on the part of the families to have their loved ones intubated. That was what we saw in the second surge. So we really had to convince them, talk to them. And because they would love to see a patient, a relative who is awake, who is communicating using his mobile, sending pictures to them or chatting with them. And we knew that this patient needs intubation, this patient needs invasive ventilation because things are pretty bad. So we had tough time convincing the relatives in the second surge regarding early need of intubation. Yeah.
So can I, will it be appropriate to say that the timing of intubation during the first surge was early? Now we can partly say that relative contraindication during that time, which was assumed that because of aerosolized spread and to prevent the spread, we rather tube the patient. Whereas in a second surge with a bit of more clarity happening, we can say that the timing of intubation was slightly delayed on that aspect of it. And I have another question on that coming in once you answer this.
See, in the second surge, we were absolutely clear that this is how we have to go. We don't have to wait. Sorry, I can't hear you. Can you repeat that, the last part?
Yeah. So the question was, there are two parts to this question. One is, can we now reasonably say that during the first surge, we intubated the patients early? And during the second surge, as the things were a bit more clear, we tried to postpone the intubation. And in this, the same question, can we say that the importance of the prone positioning, which got introduced and which the patient started getting prone during the non-invasive or the high flow oxygen therapy, that we call it as an awake proning, that which was much more prevalent or used during the second surge, did it help in the same? So the question is, intubation early during the first stage with less of awake proning, second phase, more of an awake proning, and we could postpone the intubation. What is your take on this?
Oh, yes, that's a very interesting question. I agree. By that time, there was a lot of data. I would not say concrete data, but a lot of information that was circulating around in the general public's domain also. As you would know, India is one of the largest users of WhatsApp, largest consumer of Facebook services. So everybody was aware about awake proning. Physicians were doing it. Patients were also aware about it. So we were doing it even with, nasal prongs or HFNO or those who could tolerate proning with an NIV mask. We were asking them to get proned. And compliance was an issue. Some of them would understand. They would be in that position. They would be comfortable, but others would not be. So everybody was using this awake proning because the benefits would be similar to, the proning that we do in intubated, sedated, paralyzed patients. So that was the thought. But again, one thing that when I retrospectively look at all this, I realized that, maybe if they were still breathing quite deep, the benefit of proning would be mitigated by the development of CILI. So that would be a cause of concern. And many a times the patients were reluctant to get intubated. They would say, no, let me try awake proning for some more time. So, of late now we have, some data which has been published on awake proning. So, but that's not a high quality data. There are a couple of meta-analyses that have come from India. All India Institute has published one, the respiratory group from there, and a couple of them from China and one from US. So these are available. Thank you for sending them to me. So what I've seen is the quality of studies is very poor. There are no RCTs there. And it is very, very difficult to interpret those completely dissimilar kind of studies. But one thing that comes out is that apparently it reduced the incidence of intubation. Again, we can't say with certainty that there's a lot of heterogeneity in these studies, but could be so maybe, an RCT is required in maybe normally RDS. If we try awake proning initially, then we will get an answer to this.
I think it will be also difficult to get an ethics approval with an established treatment for an early ARDS or moderate ARDS if we try to do an RCT where we tube one patient, we don't tube a patient. I think that might be an issue.
I agree. I agree with you.
Yeah, but so while the intubation got pushed back or a little bit postponed with a better results with non-invasive high flow and proning, once these patients were getting intubated, so that means we have now, as compared to the first surge, we have now in the second surge of filtered patients who are really sick. They have gone beyond the proning, they have gone beyond the high flow, they have gone beyond the NIV. And when you tube this patient, did you feel any difference in the approach, or it was the same standard ARDS approach that helped, or were there any difference in the settings that help you to mitigate these patients through the COVID ARDS in an intubated patient?
Thank you. That's a great question. Yeah. So that's a great question. Now, here we were surprised that, even with PEEP going to just 12, they would start developing barotrauma. And we have never seen such high incidence of air leak, whether it is just limited to subcutaneous emphysema or pneumothorax, frank pneumothorax or pneumomediastinum. So we couldn't use high PEEP in majority of the patients. We were trying to, even maintaining the driving pressure well below 15, we found there was significant air leak. So these are very fragile lungs. And we were sort of using low PEEP in, I would say, less than 10. 10 was the limit that we were using, because otherwise we found there was a lot of air leak in these patients. Despite using heavy sedation, paralyzing them. So that was something quite different than the conventional ARDS, where we found that if the compliance is very low, if the lungs are pretty bad, there is whiteout, then we can go very high on PEEP. So look at the ARSNet table that they had published for the ARMA trial and used subsequently also. That would have been a disaster if we had used such high PEEP, because that will lead to frank barotrauma in these patients. So they were different that way. And again, the de-recruitment would occur very, very frequently with any small stimulus in these patients. So the good effect of oxygenation that we had achieved, if somebody did a suction, that will be completely mitigated. So there were a lot of ups and downs in terms of, betterment of these patients.
Right. So in terms of ventilating this patient, as you rightly said, that it was more of a low PEEP approach rather than a high PEEP approach for this patient to keep the alveoli open. But in that case, how did you manage to maintain the driving pressure? Was it the use of the neuromuscular blockers and keep them sedated and paralyzed, or how did you manage to, or putting pressure control ventilation? How could you manage the maintenance of driving pressure less than 15?
It was a combination of all the things. So most of the patients that we intubated, we used neuromuscular blocker for longer periods, not limited to 48 hours, much longer periods. We sedated them as well. So majority of them would be on fentanyl infusion or sometimes dexmed infusion, along with occasional propofol and midazolam also. So, pressure control modality was the predominant modality that we used. So I would not say that we achieved the target in most of the cases, but we tried to do that. And we were limited by development of respiratory acidosis. So that was one limiting factor when it reduced the pH significantly. So that was one problem that we encountered in the most sick patients. So there we would then consider for, if we have tried proning, then we would suggest to them about ECMO. So these were the patients who would consider that they are failing the conventional ventilation. So the ECMO would be the only rescue now.
Therapy. Okay. But then coming to those, then in that case, coming to those patients who responded well. So we have seen in the COVID that it wasn't a 1 week affair or 2 week affair. It was mainly going beyond 4 to 5 weeks affair, and we need to keep continuing support because we have seen that the recovery was taking 6 to 8 weeks in many cases, and it's been ventilated well. So practically, it wasn't possible for us to keep continuing paralyzing the patient for that many of weeks. So in that case, at some stage, probably we were coming to the level where we need to just sedate the patient. And when we were just sedating the patient, there were chances that the patient was breathing up. So, and I understand that we were accepting it. If the patient is breathing, maintaining a good amount of oxygen, then we were continuing to support them with the pressure support or the PEEP. But this concept of when the patient is breathing along with the ventilatory support or the ventilate on a control mode of ventilation, some amount of dyssynchrony, I'm sure, would have happened. And in that dyssynchrony or the variable stimulus which a patient gives once he takes a deep breath would surely cause some kind of lung injury. I would suggest that, because this is not the same pressure which is breathing. I think that brings me to the concept whether this patient self-inflicted lung injury, that PCLI, that was the concept which was proposed. Do you think that this concept would have played a major part, especially in patient in the later part of the weeks, like week 4, week 5, when they are still ventilated, in inducing more injury and probable poor outcome as compared to our standard ARDS?
Probably, yes, you're right. Because you see, when we stopped using the muscle relaxants, we allowed them to be on assist control mode so that they can breathe. And like you rightly said, that the weaning took quite a while. So it was not like, 3-4 days you would be extubating them. It was, maintaining adequate level of oxygen, pH, carbon dioxide would be very, very demanding in these patients. And I agree with you that when they are breathing in assist control, then obviously if they are breathing very deep, because you can't all the time, use the neuromuscular blockers. So you would be depending on sedatives. And there would be instances when you would try to wake them up, you would try to assist them. So the significant development of transpulmonary pressure would definitely have contributed to the injury. That's what CRITIC is. So I agree, but then we had no choice. We were feeling helpless like the patient. So everybody across India, when we would exchange notes, people would say, "Oh, you have intubated. Good luck to you." So people knew if you don't intubate, then also it's bad. If you intubate, then also it's bad. So this was really extremely difficult. And when we teach our students, we present them a very simple algorithmic approach, which gives them the impression that, okay, we move from here to here and the patient survives. So here, the patient was not surviving despite whatever you were doing. So that was the sad part. But yes, CRITIC would have contributed significantly here as well as in the early part also when they were not intubated, both the components.
All right. Okay. So lot of things, I guess, are still not very clear, which we thought we are going towards a light at the end of the tunnel, but this tunnel seems to be going a bit more farther, and we are just seeing the light. So having treated the patient, and now in almost 2 years we are, if you get this COVID patient now, how would you do the things differently than what you have done in Surge 1 or Surge 2? What would be your practical approach if for the viewers, if you can give, for the other students and the other colleagues, if you can give 1, 2, 3, 4, 5, 6, based on the experience and the data available, how would you manage the current COVID worsening patient?
Sure, that's a great question. Difficult to answer, but anyway, I would say I'll stick to my basics. So that's what we didn't do. So I'll stick to my basics and I will follow the algorithmic approach. If they need to be intubated, if they fulfill the criteria, go ahead and intubate them. There's no need to wait. So don't be afraid of intubation, because then you are reducing the work of breathing significantly. You are reducing the villi, and follow the principle of protective lung ventilation. Be concerned about driving pressure and transpulmonary pressure, and prone them early, at least 16 to 16 hours or more, if they are not responding to the conventional lung protective strategy. And once you find that things are not working and things are going beyond, you are not able to control your driving pressure, your plateau pressure, or oxygen targets or the pH targets are not being met, then discuss about putting them on ECMO early on, because the benefit would be early. Once they reach the fibrotic stage, then they would not respond to ECMO. So that's what we saw. Another thing that we saw across India was those who were, those who underwent ECMO, late, majority of them died. So the survivors were those who were put where the family was also supportive, and they took an early call that yes, okay, we will allow a loved one to be on ECMO. So that's the message. Never deviate from the classical teaching. That's the way. And be concerned about these are fragile lungs. Be concerned about the barotrauma. So that classical high PEEP approach will not work here. So that's what I would advise the youngsters.
Yeah, thank you, sir. Just a last question before you go. What would be the futuristic take-home messages from this COVID experience? As far as now, COVID probably might fade away in next 1 or 2 years. It may remain as an endemic though. But what data can we extrapolate to the other ARDS, ARDS of other etiologies? What data can we extrapolate, or the lesson learned from the COVID, and we can use it in the other?
See, what we have seen is possibly ARDS is a very simplistic syndromic approach where we dump everything that this is ARDS. We possibly have to take a different viewpoint and maybe a phenotypic approach. For example, the CARS was completely different. This behaved completely different than the conventional ARDS. So the researchers need to focus more on these, these kind of ARDS where the lungs are severely damaged, where recovery is taking a long time. Lungs are scarred even after recovery. So there is a significant post 3 or 6 months, problem that continues post COVID or long COVID. So I think this is something where we still do not have all the answers. So, I will wait for some data, more data to be published regarding our experience and what were the factors where to reduce the mortality in these patients. We know there are a lot of studies looking at biomarkers, suggesting about biomarkers, their association. But again, that is not very clear. Some say that those biomarkers are acute phase reactants. They lose their value in the long run. You need not repeat them quite often. So we still have a lot of unanswered questions. So I would be looking at some data that is likely to be published, maybe from Indian subcontinent or from Europe or US, so that we know more about it. For example, convalescent plasma. We were using it like anything, and the families would demand. There was a lot of media, positive media report also. But now we know that this was useless. We also published a paper where we said that it doesn't really work. So we need more. Yeah, we need more data. There is one major letdown in this entire COVID second surge, that we couldn't focus, we couldn't plan any study. So I do not know whether any randomized control trials, except the drug trials, will be published soon.
I think it's practically it will be extensive depth and a wonderful take-home message. I'm sure our viewers will have a good take-home message and would definitely get enlightened with the new points and the messages which you have given us based on your experience. Thank you again for joining us on this expert talk, and I thank ISCCM Hyderabad for giving me this opportunity.
Thank you very much. Thank you. It was a pleasure talking to you. Thank you.
Thank you very much, Dr. Pande, and thank you very much again, viewers. All the best.